For you to give us the green light. We're live. We're live on both. It's exciting. So what we usually do, Laura's with me today, guys. Thanks for tuning in. I'm Dr. Steve Petteruti. This is Intellectual Medicine, the Drip Bar. And this is our informational, what do we call this, Gina? Podcast?
Podcast.
By golly, we have a podcast.
Behind the scenes.
And Gina's behind the scenes today because I have Laura with me. And Laura is a fascinating human being, intelligent woman, who has had breast cancer and is now doing things that you'll be hearing about over the next few minutes to help prevent it from coming back. It's part of our theoretical approach to what we call secondary prevention, which we're going to talk about today. Why? Because we don't want to talk about COVID. That's like, right, up to here already. Look, I understand it's tragic. It's happening. We're doing what we can, social distancing, wash your hands. Here's the problem. We got nothing. There's nothing to do to fight this disease. They've sent us to war with squirt guns and pool noodles. We got nothing. And it's discouraging, you know. So do you wear a mask when you're out and about?
Only in the grocery store.
So the grocery store, the masking. And masking has been colossal in Hong Kong, in South Korea, where the culture is such that they routinely mask. And they have ascribed that to a reduction in cases in Hong Kong, which is 7.4 million people jammed in a little space, kind of like Manhattan. And they've had really minimal transmission. The problem is you can't get a mask, and you will not be able to get a mask for the foreseeable future. You know why? You want to hear the mask story? It's fascinating. I'll tell you.
Yes.
So the U.S. manufacturer of masks during the last pandemic, which was H1N1 around 2009, got a surge of demand. They ramped up their factory. They hired 150 people. They bought all equipment, and they started knocking out masks like crazy. U.S. producer, one of the biggest. Then the pandemic went away, and you know what happened? Everybody went back and bought their cheap masks from Mexico and China. And the company that ramped up like that almost went bankrupt. And at the time, they were saying, this is wrong, because in a pandemic, every country takes care of their own. That's why we can't get masks. And that's why you can't just make them, because you have to build equipment, you've got to hire staff, it takes a while to ramp up. So now we do the shield thing, like the
Scarf.
Cowboy scarf over the mouth, right? We know that doesn't work as well as a surgical mask. That's been proven in research studies. We don't know if it works at all, but here are some details, folks. If you're going to wear a scarf, remember it gets dirty. It's like your underwear. You use it and you wash it. You do no more than one per day. You don't stick it in your purse and bring it out again tomorrow, or your pocket. Here's another detail. Do not touch it. If you touch it, it's contaminated. And not only is it contaminated, but it's a damp environment that can reproduce virions and put them closer to your mouth. So don't touch it. And if you do, wash hands. I think the mask may have some value if used properly. But we're going to segue a little bit from that because, look, we're doing our best. The COVID pandemic will go away. But heart disease, cancer, and dementia will not. And when you're fighting these chronic illnesses, you know your immune system's already knocked down a peg, and you've got to build it back up. And that's partly the reason why I want all my patients battling chronic conditions to be more conscientious. Keeping your immune system working, the risk factor for death from any cause. The number one risk factor for any disease, cancer, heart disease, dementia, is age. Number one risk factor. The number one risk factor for dying from COVID, age. What do they have in common? What is it about aging that makes us more at risk? We believe there are a couple of variables. One of them is an accumulation of toxins. Lead and cadmium and others corrode the body over time. The second one is a depletion of the micronutrient environment, the hormonal environment, and also mitochondrial health and well-being. So we restore those things. At the drip bars, we're doing shield IV infusions that are intended to support immune function, that have zinc and have vitamin C in them. Those are helpful in giving the immune system what it needs to work properly. But let's turn for a moment. Laura has faced the devastating disease of breast cancer. Speaking of pandemics, it is really 1 out of 8 women in America will suffer breast cancer at some point in their lives. That's shockingly high. And it's different in America than in other countries. The rates are lower. Why is that? We're not certain. It may have something to do with the way that we live and eat. Those toxins we spoke about, one of them is cadmium. Cadmium is a heavy metal that's known to be carcinogenic. It accumulates in the body, and it's been correlated with prostate and with breast cancer. Another factor in America is the pandemic of obesity. Excess adiposity, fat growth increases cancer risk, especially breast, prostate, thyroid, pancreas, lung, about 18 different ones. So even if you have no risk factors, if you do everything right like Laura does, you live healthy, you exercise, you eat smart, you do everything right, it can happen. So how was that diagnosis made in you? What was the first clue?
That I had breast cancer?
Yes.
I felt it.
So you felt the lump. And at that point, and that was how long ago?
August of 18.
So August of 18, and coming up on 22 years. It'll be 2 years this August.
Yes.
And at the time you felt it, had there been mammograms happening on a regular basis, or
yes, the year before.
So the year before the mammogram was performed, did they see that lump on the mammogram?
No.
So there's a take-home point, folks. Mammograms are certainly not infallible. They're a flawed study that might have some value, but is not something you can rest on. And I still like women doing self-breast exams. I think a monthly self-breast exam just makes sense. It actually is being discouraged by some authorities. They feel that you don't know how to do it right and you'll just screw it up. I mean, how can you mess that up?
Pretty hard.
It's like, so you felt the lump. What happened next?
Called you.
Okay. And then after that?
Got diagnosed. Went for a MR breast sonogram.
Right.
Which led to a breast MRI, which then led me to be diagnosed that it was in both breasts.
Okay. So the MRI showed evidence of cancer in both sides.
Yes.
When we examined you, we noted the lump on one side.
Correct.
And then that workup, how did they know to do the MRI of both breasts? That's not common. So let's talk about that for a moment, because at the point of diagnosis, that had a sense of urgency, like let's get this done fast.
Correct.
And there was also, though, a need to go more slowly to get information.
Yes.
Because I remember they were both, right?
Yes, I wasn't operated on until the end of October, and September was nothing but tests.
Okay. That must have been
It was grueling. Grueling.
So sometimes what happens, and so there's a point here, folks, when you discover a new problem in the absence of a life and death circumstance, you have more time than you think. We'll talk about that in a minute. That breast cancer was likely there for years before that lump occurred, and we're going to talk about that and why it connects to what you're doing now. So the point to our listeners is that take a breath, get information. So you go to see the first doc at the time.
Yes.
Was there a recommendation for surgery at the first visit?
Yes, there was a very minor surgery.
Okay. So you had the lump, referral was made to a surgeon.
Yes.
And the surgeon wanted to do an operation.
Yes.
And you could have booked that operation that day.
Correct.
Did you book it that day?
No. I went for a second opinion.
She went for a second opinion, but you were nervous and you were like chomping on the bit.
Yes.
Why didn't you book it that day?
Because I wanted a second opinion. I wanted to make sure that I was doing the right thing.
Laura, have you always been this assertive? I love that, right? We call this medical assertiveness. Because here's something, right? We're expert, doctors are experts, we know medicine. Mm-hmm. Who's the greatest expert about your body, about you? Well, you are. Right?
That's right.
There's an innate sense that folks have about their own health, about their own well-being. And you certainly know philosophically. And we'll talk more about that. So you had the presence of mind to slow everything down, get a second opinion, which I always recommend. And that second opinion, by the way, it shouldn't be the main surgeon's partner. It should be a completely separate watershed. So here's one of the things that I always recommend that you consider is stepping outside of the the pond where the diagnosis is being rendered. What's happened in medicine, I'm going to editorialize for a second.
No problem.
It's become vertically integrated. What does that mean? It means that the primary care doctor, the surgeon, the hospital, the x-ray technician, the radiology suite are all part of the same company. That's not intrinsically evil, but there is kind of a built-in conflict of interest of sorts, right? If I am a primary care doctor and I work for Medicine Inc., and I'm routinely referring people out to other hospitals, how long do you think I'm going to stay employed? Right? That could be a cause of some consternation by the people who are signing my check. What's wrong with our surgeons, they may say. Well, nothing. I just like getting other opinions. Oh, do you? So my point is that if you know that, it's not wrong, it's not bad, and there's some value in familiarity, there's also a risk. Right? So my patients ask me, who are my friends and doctors? And then I tell them I have no doctor friends. It's not, I like my colleagues. They're wonderful people. But when I'm advocating for a patient, I don't care other than where you need to go. And in my opinion, when you have time, we live in the Northeast and you have Mass General and you've got Sloan Kettering and you've got some of the finest centers in the world in our backyard.
That's correct.
No knock on the local team because they're quite excellent. But you ended up getting a second. Where'd you get your second opinion?
Mass General.
Went to Mass General. That doesn't stink. Look, if King Fahd from Saudi Arabia could fly here for it, it's good enough for me, at least getting the opinion.
Yes.
And getting a second opinion is great, but you can get a third opinion. And most insurances are going to pay for multiple opinions when you have a difficult diagnosis like cancer until there's alignment, until they're saying the same thing. What was the opinion in Mass General? Was it the same as the one that
Initially.
Okay.
And then they did more tests, which led to more tests, which led to the final diagnosis.
What made them do the more testing? Is that part of their routine?
Yes.
Okay. So they had a different approach.
Yes.
All right. So there you are. The diagnosis is now, by golly, both sides. I guess you felt comfort is the wrong word. Satisfied that you'd pushed forward and gotten the other opinion.
Yes. And they were thorough. So I was very comfortable.
What happened next?
They operated.
What kind of surgery did they do?
Double mastectomy.
Okay. Whereas it would have just been on one side.
Lumpectomy.
And the cancer on the other side would have still been there.
Because they didn't see it.
They didn't see it. You can't see it if you don't look for it. And herein lies one of the caveats, team. Just because you can't see it doesn't mean it's not there. There's tumors and there's cancer cells, and those two are different players. Unless we see it, we can't operate on it. And they were able to see it through the MR.
Yes, the 3D.
Yeah, 3D. Okay, so surgery happens. What other treatment do they do? Did they do any chemotherapy before surgery?
No.
Okay.
No, and I had no chemotherapy after, just radiation.
So they did local radiation?
Yes.
And they decided not to do chemo. They just felt based upon the cell type that it wouldn't be totally effective.
It'd be as effective as hormone therapy.
Okay. So it was an equivalency. Years ago, not that long ago, chemotherapy was almost universal. What we have found since, and this is where your oncologists come in. I am a family physician, and my specialty and background is in complementary support to fight cancer, including intravenous vitamin C, which we'll be talking about in a moment. But you always want to have an oncologist part of your team because their fund of knowledge is different and complements the knowledge of people like me and your family doc. So what we've learned about breast cancer is that not all cell types benefit from chemotherapy. And some women, back then were getting chemotherapy without net benefit. We just didn't know it at the time. So I recommended hormone therapy and sent you home on hormone blocking treatment.
After I had the radiation.
Okay, so radiation, and your breast cancer was hormone receptor positive.
Yes.
So that means that the cells are sensitive to estrogen and progesterone.
Correct.
And that we believe the estrogen and progesterone can make the cancer more likely to return. So the next step in treatment is to give you prescription drugs that block estrogen production.
Correct.
And blocking estrogen production has been proven to diminish the risk of relapse.
In 5 years.
In 5 years. because they usually only do it for 5 years.
Correct.
5 years. Why do they only do it for 5 years? Well, it's got consequences. And some of those consequences you feel. So you went on this, after the surgery, after the radiation, some of my patients who have been through cancer complete their treatment, get through their chemo, and then they're discharged. They kind of feel a little bit let down.
Oh, yeah.
Did that happen?
Yes.
Talk about that.
Well, I would go back and then I'd ask, well, what are the signs? How do I know this is gone? And they said, well, if you have persistent pain for 2 weeks, go see your primary care physician.
Okay.
So I felt there was nothing I could do to help prevent this from coming back other than take the hormone blocker.
And that leaves and that's a common feeling. It's a sense of emptiness.
Mm.
That's it. I wait and I wait for the other shoe to drop.
Right.
Did you go on the internet and search for stuff like that might help cancer? Did you ever Google that? You really didn't need to because she had me.
That's right. That's exactly what I was going to say.
So we've been together a long time.
Yes.
It's been years.
Yeah, 5, 6 years.
5 or 6 years. And Laura's part of my primary care practice. I'm very honored to have her part of that family. And also partaking now in secondary prevention. So let's focus a little bit on this sort of post-treatment phenomenon. One of the problems with cancer is the only way that exists for conventional, one of the primary ways to follow this up in conventional medicine is imaging. You come back every so often. Do they have a plan to image you?
No, because there's nothing.
Nothing image. So if the cancer comes back, let's talk about breast cancer more specifically. When the cancer comes back, if it comes back, it doesn't necessarily come back to the other breast, although it can. It can go anywhere. They talk about pain. What they're talking about is bone. You get breast cancer coming back to the bone. That's a bad outcome. That's a terminal disease state. It's not curable. It can go back into the brain, into the liver, into the other organs. So what do? You can't image the whole body every 3 months that you'd glow in the dark from radiation. So they just wait. You wait, and that's not unreasonable. But now we've got other tools and other options. And here's the tough part. We talked earlier about COVID, about the lack of proof of any intervention. What we're about to talk about lacks proof of absolute benefit. It is not FDA approved. It's not been shown to diminish the rate of cancer relapse. But there's a certain logic, there's a science and a rationale behind it that makes sense. So let's talk about cancer on a cellular level. Every cancer starts on a cellular level. What that means is you can't see it, you can't feel it, you don't know it's there, it's just growing while you wait. It's called doubling time. 1 cell becomes 2 cells, and that's the beginning. And this doubling time can take as little as 2 weeks and as long as 90 days or longer, depending on the type of cancer. Breast cancer seems to be in the 30 to 60-day range, although nobody knows with certainty, what that doubling time is, but we know it exists.
Yes.
So now we got a doubling time, and now 1 becomes 2, 2 becomes 4, etc. There's an exponential growth. Have you ever spent an afternoon with a financial advisor? And you remember those guys? And they show you that curve. Well, Dr. Petteruti, if you start saving now at age, whatever, by the time you're 103, you'll be a billionaire. Right? Like, no, this isn't going to work for me because I don't like saving money. I like spending money. That's a whole other philosophy. But the same dynamic occurs at cells. Now, it takes about 30 doubling times for a tumor to get that big. I'm showing you the tip of my pen, right? Approximately a centimeter diameter. 30 doubling times. If your average doubling time is in the neighborhood of 60 days, that can be 7 to 10 years. So it's quite likely that Laura's cancer was there 7 to 10 years ago, starting on a cellular level, undetectable. By the time it gets to be 1 centimeter, however, how long does it take to go from 1 centimeter to 2? The answer is 1 doubling time. How about from 2 to 4? Another doubling time. So you can see that exponential part. begins.
Mhm.
Now the tumors are gone. That's good news.
Yes.
Is the cancer gone? The 5-year relapse rate for stage 1 breast cancer is exceedingly low, somewhere on the order of 98 to 99% cure rate, defined as a 5-year relapse. Laura's a young woman. 5-year relapse in our world is a nice start, right? But we're not popping the cork and declaring victory. There was a very important study. It was done in the published in the New England Journal of Medicine within the past 2 years. And it looked at the delayed relapse rate of breast cancer after 5 years. What happened? Stage 1 breast cancer. Stage 1, by the way, is not what you had. Yours was stage 2B. Stage 1 is that lumpectomy. It's that little tiny, we caught it early, aren't you lucky? All we have to do is cut that out and you're going to be good to go. And your 5-year relapse rate is like almost non-existent, especially for Children's hormone. Go out 10 years, the relapse rate is now 10%. That's 1 out of 10 with stage 1 breast cancer when they go beyond and you look down the road. So that 45, 55, 60-year-old woman, it's 10, 15 years later, they have pain, they go see their primary care doctor. I'm sorry, you have metastatic disease all over your skeleton. What happened? Those cells dispersed like dandelion seeds in the summer, and they started doubling where they landed. Cellular disease, no treatment for it. What we're going to be talking about is not proven, it just makes sense. And we need to execute to learn. So at Drip Bar, we have what we refer to as a secondary prevention protocol. Not FDA approved, not proven in research studies to actually diminish the risk of relapse. So why do we do it? We do it because it's safe and because the studies have shown that high-dose intravenous vitamin C can be toxic toward cancer. We've seen it in vitro studies. In vitro means in a petri dish. So what they do in a petri dish is they take cancer cells, different types, and they've done this with many, many kinds of cancer, and they expose it to vitamin C, and they watch the cancer cells die. That's kind of cool. Well, will it work in a human body? Then they look at animals, and we see some similar outcomes. Then we look at human beings and what we call case studies. A case study, ladies and gentlemen, is simply one patient like Laura deciding to do a certain treatment, and then you observe what happens.
Yes.
Case studies have had some favorable outcomes with regard to relapse and longevity. They are not proof of outcome. The proof of outcome requires years and formal study. We hope to be accumulating that. In fact, we are at Drip Bar. We are starting to track Laura and others who have had cancer, have had it removed and treated, and are now tumor-free. And then we do once a month, a high-dose vitamin C infusion is what our protocol calls for. The theory is that if you've got 1,000 cancer cells in your body and they're trying to double, the high-dose vitamin C has a potential to kill some of them and prevent them from ever gaining a head of steam. We believe that the cancer cells are more vulnerable before they coalesce into a tumor. When the cancer forms into a tumor, it can be harder to penetrate, develops almost like a defense mechanism. So presently, Laura's tumor-free, feeling pretty good.
Yes.
No pain.
No pain.
And really no imaging happening.
No.
Because there is none to be done. So we move forward with this approach. There's another thing that we do in many cases, and we have this approach for all forms of cancer. The other things we'll talk about that are preventative that we believe are helpful. Certainly one of them is percent body fat. We analyze your percent body fat because it's relevant to cancer risk. The higher the percent body fat, the greater the risk. That has to be modified. You can't just lose weight. You've got to shrink fat. And Laura's on a good path towards that. This is something called the IV gene. It's called a liquid biopsy. I'm going to hold it up in a second. This is not commonly used. Your oncologist typically doesn't use this because cellular evidence, evidence of increasing cancer at a cellular level is not a basis for reinstituting treatment. It's simply not standard of care. So even if we do a blood biopsy and we see evidence of the cancer cells kind of maturing and growing, the oncology treatments do not apply to that. But functional and complementary care may have a role in that setting. Now, this test was done, I've got it dated here, it was July 2019.
Yes.
We like to do these in some cases once a year, and it comes back in a report thusly. It's a one-page report, and it has a quantitative numeric score. It's called the IV gene score. If it's above 20, it's considered in an abnormal range. If it's below, it's considered in a normal range. Like any test, like Laura's mammogram from years ago, it's not perfect. It has to be interpreted with caution. In July of 2019, Laura's test score was 21. It's at a panic moment. It wasn't 19. It wasn't below the threshold. It's a number. It doesn't change anything, but it gives us a metric so that we can look at it again in July and get a sense about where things are going.
Okay.
So the blood, it's called a blood biopsy, may have some value. Ultimately, we're not going to know until it's 10 years from now and Laura feels great. And then we're still not going to know. Was it a coincidence?
Mm-hmm.
So here's what Laura's risking by doing vitamin C once a month. Time and money. You could be wasting both. You ever think about it? It could be a waste of your time and money. Maybe this will never come back. It's a pure coincidence.
It's not, though.
But well, you know why it's not, and I get that too, because you're doing something.
That's right.
You're doing something, and it's not just
Waiting.
Not just waiting, and it's not in the absence of evidence. I want to say we don't have proof of outcome, but we don't lack evidence. Vitamin C has been studied, hundreds of studies looking at its impact on cancer. So I feel very confident with its safety. Its mechanism of action, it seems to work by converting to hydrogen peroxide, which is toxic to cancer cells but safe for human cells. Therefore, it's a reasonable thing to consider. It's not a requirement, but it can be considered. And some patients will do this while they're getting chemotherapy if they have more aggressive forms of cancer. In future podcasts, we'll look at other types of cancers and other stages because we're passionately aspiring to help all of our patients not only live longer, but live better. And we believe this can be a part of it. And part of that really means psychologically. I know if I were told I had prostate cancer tomorrow, I wouldn't do any conventional treatment because I don't believe they have value, personally, based on my research. But I didn't want to sit there and do nothing.
Yes.
Now, you were on the hormone therapy.
Great.
The hormone therapy is proven to diminish your risk of relapse.
Yes.
But you stopped it.
Felt terrible.
Okay, I'm going to be your oncologist for a minute. Are you out of your mind? The cancer could come back. Do you realize that your risk of cancer relapsing just increased?
I have no quality of life. I'm tired all the time. It's affecting me terribly.
Did you talk to your docs about the adverse quality of life
Yes.
issues? And
Yes.
what was their recommendation?
That just goes with it. You have to grin and bear it.
And that is not wrong advice. It's just a philosophical perspective. Right? The oncologists really measure the value of what they're doing on whether or not the cancer comes back.
Correct.
There's less focus, and this isn't universal, and the oncologists are really good, heartwarming human beings. And you've had great
I have
docs.
great doctors.
And they are really caring.
Yes.
And they've given you great advice.
Yes.
And you haven't chosen to take that advice.
Up until a point.
Right. And this goes back to that level of assertiveness. You had to make a decision between how you're feeling and the value that you were acquiring. Did they tell you how much that risk would go up by not taking it?
They did not.
Okay. Did you ask them?
No.
Would it matter?
No.
Okay. Tell us about how you felt. You said tired, run down.
My bones ached, foggy brain, tired. I just irritable. It was
Not you.
no, and it was like going through the change of life all over again.
Only in this setting,
It's not going to end.
it doesn't end. It becomes the comfort, the misery of the gathering. That is, they'll tell them, yeah, this is how it is. You're not alone. Take comfort that this is a common effect.
I asked them why they didn't tell me this would be the effect, and they said because we knew that you wouldn't try it, you wouldn't do it.
Wow, that's a little uncomfortable. They really ought to maybe be more transparent. But here's the problem, folks. A body without adequate hormones suffers. You take away estrogen, you take away testosterone, you take away progesterone. Those are essential hormones, and without them, what happens? Well, you heard some of those symptoms. Here's what else happens. There's an increased risk of dementia that has been correlated with low estrogen studies and low estrogen levels in multiple studies. There's absolutely bone risk,
Yes.
osteoporosis. Now, in 10 years, if Laura breaks a hip and dies from complications of a hip fracture, it's still an oncologic success because she didn't die from breast cancer. So it's still categorized as a success.
And I asked the doctor, I did ask them about that, and she didn't want to answer my questions and wanted me to talk to a social worker. So
About bone?
yeah, what if I fall and I break my hip and
Yeah.
my bones are very thin?
Yeah.
And they're very good. They're very focused on curing me of breast cancer. But anything beyond that,
Yeah. And this is really where, good family doc, particularly if they have a functional medicine background, you got to take a step back and look at the big picture. Here's what I know about Laura. Someday she's going to die, and me too. Right?
Mm-hmm.
Here's what we don't know. What's going to take us? Here's what we both know and agree to. We want to live rectangular lifespans and stay healthy until we're dead. Right? I actually don't mind. Well, I don't know. I do mind dying. I'd rather not die. But I like Woody Allen's quote. He said, I don't mind dying. I just don't want to be there when it happens. He said, the idea is to stay healthy. And then, you get a chest cold and you're dead. So the analogy in COVID world would be, is Steve here to play golf with us? No, he didn't show up. He got a chest cold. He died last night. Boom. At 103. Without the prelude of the nursing home and the disability.
yes.
So what Laura was on was a path of deterioration and bone deterioration. It's an uncomfortable reality that when we face uncomfortable realities as doctors, we don't have answers to smart questions. Sometimes we just rather not engage.
Correct.
And when the risk is increasing the cancer relapse rate, the patient's decision can sometimes be disparaged. Do they know you stopped the hormones?
I didn't tell them. No.
Okay. Do you have an appointment at any time? Then
A year from now.
That'll be an interesting conversation.
I'm sure.
But I think it'll be interesting, but tempered by the fact that you've had time to reflect, that you've done your homework, and that you've made the philosophical decision. Are you comfortable with it? How are you feeling now?
So much better. A lot better. I'm not achy. My joints don't ache. I get up in the morning. I feel like I'm back to my normal self.
Now, we can't say if Laura doing vitamin C infusions and if Laura working on percent body fat management and if Laura taking certain supplements that we recommend and using what we also refer to as repurposed drug therapy, and not uniquely to us, but that's another realm that's being studied for cancer treatment and prevention. Certain drugs have been shown to have anti-cancer properties. Metformin is one. Atorvastatin or Lipitor is one. Mebendazole, this is an anti-parasitic drug that has been correlated with potential benefit with cancer. Why do we mention these drugs? Because they're cheap, they're safe, and they may help. But you need somebody to help guide you through it. Please don't do this online. Don't go to a website and order it up. It's worth reflective time because everything comes at a price and a consequence. And here's the ultimate consequence. We call this philosophy of regret. So here's Lauren, we had this conversation. Suppose you stop your hormone therapy, you're doing all this other stuff, and it's 3 years from now and you end up with metastatic cancer. Would you regret having quit the hormone therapy?
Absolutely not.
It's an important detail. Not everybody would say that. Conversely, if you're on the hormone therapy and you get breast cancer, how would you feel? The philosophy of regret might be that, damn it, I suffered and I still got the cancer. Or, depending on your philosophy, it might be, well, thank God I took the hormone because I know that I did my best effort.
Mhm.
This is an individual response. Philosophy of regret is relevant here because there's no certainty with or without the hormone therapy, with or without the vitamin C therapy. I've been on hormone therapy. I'll be 61 next month. How about that?
I'm not telling you my age.
Don't. We'll stay young forever. I've been on hormone therapy for 13 years. So the question becomes, geez, Dr. Petteruti, if you ended up, having prostate cancer, would you regret anything? My answer is no. I've done my research. I believe, and many of my colleagues concur, that there's no increased risk of prostate cancer despite some of the published opinions to the contrary. And those published opinions, they might be right. I mean, this is an uncertain path regarding how we're going to move forward. So in this moment, Laura feels good. In this moment, there's no evidence of the cancer being present. In this moment, there could be cellular cancer happening. We'll never know. It's really hard to prove a negative. So as we do this at Drip Bar, we're tracking our patients. And we're looking forward in the years to come to be able to analyze this data and report it back. And what we're looking to do is create drip bars across the country. And all those drip bars are going to send information. There's a real need to have honest conversations about complementary treatments that may afford benefit, that have a possibility of helping people that are unproven. And Laura knows that what you're doing is, in essence, an experimental path.
Right.
It's an experimental path, not a blind dive. But when I'll just mention this too about these cancer protocols.
Mm-hmm.
So we all are familiar with the notion where somebody has cancer, they get treated, it doesn't work, the cancer progresses, and they want to get in a protocol.
Mm-hmm.
Those are experiments. Those are not intended to help cure your cancer. They're intended to give information to the researchers. You are a lab specimen at that point. The idea that getting in a protocol is a salvation is hopeful, but not the intent. What we do is intended to have a positive outcome, unlike a fresh protocol with absolutely no scientific background. There is, we talked before, some building evidence of possible merit. We just need to take this to the next step.
Correct.
And with courageous individuals like Laura, by the way, I would be friends with her even if she went on hormone therapy. That's not the point here. The point isn't that, isn't it great that Laura quit hormone therapy? Many patients are on hormone therapy, have had minimal side effects, are grateful for its benefit, and want to remain on it. And we applaud that and we support it. It does not, however, take away the potential merit of complementing that with vitamin C, because the conclusion of that New England Journal study, by the way, that showed that delayed relapse was maybe we should extend hormone therapy beyond 5 years. That might diminish the risk of relapse, but it may also accelerate all the negative consequences from dementia to bone thinning. So in conclusion, what we really advocate for is great information, honestly delivered, so that you can process it. And what you're hearing, and I hope you guys can role model from Laura's example, is taking a time out. In the midst of an urgency, a sense of panic. Oh my God, I have cancer, get it out of me now. I need the surgery next week. Pause and think. Maybe that surgery does need to happen next week. Maybe you're on the brink of catastrophe. That's not terribly common. Most cancers have been there for a long time, and most of the time, at the moment of diagnosis, especially in the vast majority of breast cancers, you have time to shop before you buy. Any other thoughts you want to share with listeners?
Just to let you know that when you hear the word cancer, it's like Snoopy and you just wow, 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 wow. Stop, relax, think it through, and make a conscious decision that you can live with.
It's great advice. That's great advice. Sometimes just taking the time out and
that's it.
And I would say go on a vacation, but you can't leave the state. Well, trapped.
Trapped.
Well, listen, this has been a little longer than usual, but it was a worthy topic, We hope you share this with other people that are walking this path. I'm Dr. Steve Petteruti on behalf of the Drip Bar and Intellectual Medicine. Grateful for Laura for sharing her story. That wasn't too painful. Huh?
No.
It wasn't bad. And you can come back again
Yes.
in months to come.
Sure.
We'll continue our conversation, and we'll be circling back to this topic as time goes by. Well, thanks a ton, folks. I'm Dr. Petteruti. We're going to sign off. Let me see if I know how to do this. Are you sure you want to end your stream? Yes. So we ended that stream. I'm going to end